This is the explanation for the fifth EKG of the EKG club. The purpose of the question and the EKG that was given to you is to identify the ST elevation in the anterior and anterolateral leads, the ST depression or reciprocal ST depression in the inferior leads. The patient is in normal sinus rhythm with a single PVC here. I'm sure all of you will be easily able to answer this question as an anterolateral ST elevation myocardial infarction, but we will go into the details of what causes ST elevation, ST depression, and reciprocal ST depression in the slides to come. ST elevation occurs when there is a total occlusion or near total occlusion of the coronary vessel, causing full transmural, full thickness ischemia or injury, whereas ST depressions occur when there is a partial occlusion of the coronary vessel, causing what is called a subendocardial ischemia. It is not a full thickness ischemia, but either a subendocardial ischemia or infarction, where just a small portion of the myocardium closer to the endocardium is injured. In order to understand how ST changes happen during ischemia and infarction, you need to understand the electrophysiological changes that happen at the cellular level when you have ischemia and infarction. When you block the perfusion to an area of the myocardium by either a total occlusion or partial occlusion of the coronary vessels, you have decreased blood flow or perfusion to the myocardial cells. That causes severe decrease in oxygen supply or hypoxia that leads to loss of ATP from the myocardial cells. That ATP loss then causes decreased function of the sodium-potassium ATP dependent pump that then causes two changes in the myocardial cells. One, it causes a sustained membrane depolarization. It is almost like those cells are depolarized all the time without getting repolarized. And in the surrounding myocardium, even when it does get depolarized, it actually has shortened action potential duration. So these are the two effects that you will see in the cells when you have hypoxia. Then that will explain how ST elevation and ST depression are formed during ischemia and infarction. Before I go into the details of how an ST elevation or ST depression occurs during ischemia, I want to show you some parts of the EKG that could be useful in discussing those changes. When you see EKG rhythm, the space between a QRS complex and the next QRS complex is called the RR interval. The RR interval, even though it's like a baseline, has several different components to it. The first part of the RR interval, beginning from the QRS complex onwards, is the ST interval, which starts from the end of the QRS complex to the end of the T wave. The next segment is from the end of the T wave to the beginning of the next P wave, which is called the TP interval. And the last part of the RR interval is composed of this PR interval, which starts from the beginning of the P wave to the onset of the next QRS complex. So that three components make up the RR interval. Subendocardial ischemia causes ST depression. As I told you before, subendocardial area is the area of the myocardium which is just below the endocardium. And when that small region of the myocardium is either infarcted or ischemic, remember the changes that I mentioned before, the sodium-potassium ATPase pump is not working well, so this part of the myocardium has a baseline depolarization that is always there. Therefore, that depolarization is sensed by the ECG electrode at baseline all the time, and therefore the PR interval is always elevated from the baseline. So then the rest of the myocardium, when it gets depolarized, you have a QRS complex that happens for a moment. The ST segment comes down to the baseline and then T wave is formed. And then after the rest of the myocardium is repolarized, remember this part of the myocardium always remains depolarized. So therefore the ECG returns to this baseline depolarized state in this electrode, and therefore your PR segment is still going to be elevated. So when in fact the PR segment is the one that is elevated, when we look at an EKG, subendocardial ischemia or infarction looks like there is an ST segment depression, which is what we see and interpret. We call that ST segment depression, when in fact the actual changes that happen in the EKG is a PR segment elevation because of this small amount of myocardium that is always remaining depolarized, sensed by the ECG electrode. When you have a total occlusion of the coronary vessel, you have a full thickness ischemia or infarction. This causes ATP changes in the myocardial cells in the entire thickness of the myocardium, sending electrical signals or impulses away from the sensing electrode, and therefore your resting PR segment is always negative. So here is the baseline voltage, and your resting voltage of the EKG is always below that, and therefore your PR segment is depressed. During ventricular depolarization, the entire myocardium gets depolarized, so therefore you get a QRS complex, and then you reach the zero voltage after the QRS complex, which keeps the ST segment above. When the repolarization is complete, you come back to the baseline, which is the PR segment again, that is below the baseline, and therefore you get this EKG abnormality that looks like the ST segment is elevated when in fact the baseline PR segment could be depressed, giving you this appearance of an ST segment elevation. So here is the summary of the changes that happen in the ECG because of the changes in the cellular electrophysiology. During a transmural infarct, there is a baseline depolarization of the entire thickness of the muscle due to changes in the sodium-potassium ATPase pump that moves the PR segment or the baseline voltage below zero. And when there is a QRS complex and depolarization of the ventricle, there is an upward shift in the ST segment. These together will cause the ST segment elevation. When you have a subendocardial ischemia or infarction, which is not a full thickness MI, there's not a total occlusion of the coronary vessel, your PR segment, because this small portion of the myocardium is always depolarized, is elevated. It goes above the baseline, and then there is a QRS complex and there is a downward shift in the ST segment. Therefore, it causes this ST segment depression kind of appearance. Where in the EKG leads you see the ST segment elevation is usually indicative of the region of the myocardium that is undergoing injury or infarction, and it also points to the coronary territory that is being involved. If you have ST segment elevations in lead 2, 3, and AVF, which are the inferior leads, you have an inferior infarction, which usually involves either the right coronary artery or the left circumflex artery. If you have ST segment elevations in V1 and V2, usually it is a septal myocardial infarction. V3 and V4 are the anterior wall of the left ventricle, so it's an anterior MI. And these 4 leads usually are indicative of obstructions in the left anterior descending artery. V5 and V6 and leads 1 and AVL, if you see ST segment elevations in these leads, usually it's indicative of a lateral wall myocardial infarction, and usually it involves either the diagonal branch of the left anterior descending artery or the left circumflex artery. Here is a summary figure showing that right coronary artery, usually it's an inferior infarction with 2-3 AVF changes. Left circumflex artery sometimes can cause lateral wall changes in AVL, lead 1, V5, V6, and usually V1 to V4 are left anterior descending artery occlusions. The timeline for the changes on the EKG that is reflective of what is happening in the underlying myocardium is shown here. So this is a normal EKG. Within seconds of a complete occlusion, you will have something called a hyperacute T wave. A hyperacute T wave is basically an ST segment that is super elevated and merges with a very tall T wave. So hyperacute T waves occur within seconds of occlusion in the coronary artery. Within minutes to hours from that point on, your ST segments slowly come down. You see a discrete T wave that is elevated. So you have that coving ST segment elevation or tombstone pattern. And within the first few hours, you will start to see a Q wave form in front of the QRS complex. This is because of loss of voltage because of the dead cells of the myocardium. You will see within the first few hours. Within the first 24 hours, you will see ST segment elevation, Q waves, and T wave inversions in the same leads. And within days to weeks, you will see the ST segment elevation resolve. Your T wave inversions will still persist, and your Q waves will still persist. After months, you will not see any more T wave inversion. Your Q waves will remain, and this is how the patient's EKG will look like for years to come after that. We're going to talk a little bit about ST segment depressions in ischemia. Remember, I told you that when you have a subendocardial ischemia or infarction, you will have ST segment depressions. You can also see ST segment depressions during an ST elevation MI in the leads that are opposite to the region of the myocardium that is undergoing ischemia or infarction. Those are called reciprocal changes. So reciprocal changes can cause ST segment depression, as well as subendocardial ischemia can cause ST segment depression. In either case, the more concerning ST segment depression is usually an horizontal ST segment depression. As you can see here, this ST segment is very horizontal, just parallel to the baseline. This is much more concerning than either an upsloping ST segment depression, which is usually normal, or a downsloping ST segment depression, which usually occurs due to other repolarization abnormalities like left ventricular hypertrophy and things like that. In either case, you still should take a downsloping ST depression seriously, but the most concerning one of all of them is a horizontal ST segment depression. This slide talks about reciprocal ST depressions that happen during an ST elevation MI. Remember, when you have a transmural infarction, or the full thickness of the myocardium is injured or infarcted, you have changes in the sodium potassium ATPase pump that drives the electrical impulse away from the sensing electrode, which is here, and therefore your baseline PR segment is depressed, and therefore your ST segment appears elevated. So if you have a sensing electrode, another ECG electrode on this side of the myocardium, on the opposite side, then that electrode senses this baseline depolarization coming towards it. Therefore, the baseline PR segment is elevated, and therefore after the QRS complex is done, it comes back to baseline that looks like an ST segment depression. So these changes that happen in the electrodes that are opposite to where the MI is happening is called reciprocal ST depressions. So these reciprocal ST depressions are not showing you what is happening in the myocardium just underneath where the EKG electrode is. It's actually showing you what is happening in the part of the myocardium that is exactly opposite to this electrode. So therefore, this is kind of like a mirror image of the ST segment elevations that you see in this electrode, which is why we call them reciprocal ST depressions. Sometimes reciprocal ST depressions is all that you will see during an MI. For example, if you have a posterior wall myocardial infarction, all your electrodes are in the anterior part of the chest, so you're not going to see ST segment elevations in any of the leads. But what you will see is significant ST segment depressions in lead V1 to V3, which is just basically a mirror image of what is happening in the posterior part of the myocardium. So therefore, sometimes reciprocal ST depressions can lead to diagnosis of a posterior wall MI. When there is an ST segment elevation, where these ST segment elevations are found can tell you which part of the myocardium, LV myocardium, is undergoing ischemia or infarction. Here are the reciprocal changes. So when you have a septal or anterior wall myocardial infarction, you will see some of these changes in the inferior leads in 2-3 AVF. Sometimes you may not see any reciprocal changes. Sometimes you might see them in the lateral leads in V5 and V6. When you have lateral wall infarction in leads 1, AVL, V5, and V6, you definitely see ST segment depressions, which are reciprocal changes in leads 2, 3, and AVF. If you have an inferior wall myocardial infarction, you will see the ST segment elevations in 2, 3, and AVF, and the reciprocal ST segment depressions are usually seen in the lateral leads in V5, V6, lead 1, and AVL. Of the choices that were given to you, these are the choices that are wrong. Number 1 is pericarditis, because you do not see any diffuse ST segment elevations. The ST depression is not explained by pericarditis, and there is no PR depression in these EKG leads. It's not a first degree AV block because the PR interval is less than 200 milliseconds. It's not left ventricular hypertrophy because none of the QRS complexes meet the voltage criteria for left ventricular hypertrophy. And there are inferior ST segment depressions. Usually LVH causes more anterior ST segment depressions. It's not a left bundle branch block because the QRS duration is less than 120 milliseconds. It's not hyperkalemia because the T waves are not peaked and sharp. Also, hyperkalemia does not cause ST segment depression. It only causes T wave changes. It is J point elevation. The J point is elevated during an ST segment elevation MI, but this choice basically alludes to early repolarization changes. This particular EKG does not show early repolarization because in early repolarization, you do not see any ST segment depressions. You only see J point elevations. It is not left axis deviation because the QRS complex in both lead 1 and 2 are mostly positive. That goes towards a normal axis or a slightly leftward axis, but still normal axis. It is not a posterior wall ST elevation MI. Remember, I told you sometimes the reciprocal changes that you see in leads V1 to V3, which is basically ST segment depressions in V1 to V3, can be indicative of a posterior wall ST elevation MI. But in this case, the ST segments are elevated in these 3 leads. Therefore, it is not a posterior wall ST elevation MI. So therefore, the answer to this question, it's an anterolateral STEMI. So the full thickness injury or infarction in the anterolateral walls of the left ventricular myocardium is causing the PR segment to be depressed below the baseline and the ST segments to be elevated in these anterolateral leads, which is seen by the electrodes that are completely opposite, which are basically the inferior leads. So therefore, they are seeing the ST segment elevations as ST segment depression. So basically, these ST segment depressions in leads 2, 3, and AVF are kind of like a mirror image or opposite from where they are located. You also see a single PVC. How do you know it's a PVC? Well, it's wider QRS complex compared to the normal baseline QRS complex. It comes early or premature, so therefore this is a premature ventricular complex. I'm not going to go into the details of whether this is a PVC or PAC. We'll keep it for another time. This will end the explanation for ECG number 5.